Hey guys, welcome back. Let's dive into the dermatology section of the musculoskeletal chapter. We'll start with a quick intro to the anatomy and physiology of the skin, and then jump into the high-yield skin lesions and rashes that will get you some of those quick points for spot recognition. The skin is the largest organ in the human body. Do you remember the 5 layers? The stratum corneum, lucidum, granulosum, spinosum, and basalis. You can remember this fact with the mnemonic, Californians like girls in string bikinis. Also note that the stratum lucidum is only present in the thick skin of the palms and soles. Now how can you remember this? Think L for lucidum is the only letter in the acronym that's in both words, palm and sole. This diagram covers a fairly important set of topics. The structures we're about to discuss provide the integrity of the epithelium and allow cells to have specific functions. Here's the apical side of the cell, and the basolateral side of the cell. The first structures we'll discuss are the different junctions that are key to forming the body's outermost barrier. Tight junctions, or zona occludens, are found apically along the rows of epithelial cells. They prevent diffusion across the paracellular space from large molecules to even individual ions. They're made of 2 molecules, claudins and occludens. Ultimately, they form a zipper around cells. Just remember that the tight junctions bind so tightly that they don't allow most substances to pass. The next structure is the adherens junction, or intermediate junction. This surrounds the perimeter just below the tight junction. The functional proteins that form these intermediate junctions are called cadherins. They attach to the intracellular actin molecules which normally function in the cell's own cytological skeleton. What is an important ion to cadherin function? They rely on calcium, hence the name, which is derived from the phrase calcium-dependent adhering protein. So if you ever can't remember what ion is important in their function, just remember that it's in the name. Next we have the macula adherens, or desmosomes. How are these connections different? These are literally small, discrete sites of attachments, much like a drop of glue. They utilize the same proteins, cadherins, but rather than attaching to intracellular actin like intermediate junctions, they attach to intracellular intermediate filaments. And yes, we recognize this is pretty confusing and maybe even be a little bit backwards. But why do we care about desmosomes? Because they are the key to pathology in pemphigus vulgaris, which we'll do a bit more in-depth review of in the derm section. Briefly, patients have autoantibodies to these spot junctions, often most visible at the level of the skin. If you think about it, if all the epithelial cells lose their spot junctions, they would lose their ability to hold on to one another. And what would happen? Well, they would separate. If this happened in enough areas throughout the body, it would form large blisters, which is the characteristic presentation of pemphigus vulgaris. A similar structure to the desmosome is the hemidesmosome, which you see here at the basolateral surface of the cell. It's called a hemidesmosome because it literally functions like half of a desmosome. It doesn't connect 2 cells to one another, but rather one cell to the basement membrane at the basal portion of the epithelial cell. Similar to pemphigus vulgaris, patients that develop autoantibodies to these hemidesmosomes will develop a different blistering disease named bullous pemphigoid, which is probably the setting where you're most likely to see these structures appear on a test. For step 1, you'll need to pair these in your mind: pemphigus vulgaris and desmosomes, and bullous pemphigoid and hemidesmosomes. Additional structures are also used to maintain the integrity of the basement membrane, and these are integrins. They function by binding to laminin in the basement membrane. A final structure found on epithelial cells is the gap junction. These junctions allow adjacent cells to communicate for electric and metabolic functions. This provides an efficient and effective way for one cell to communicate to another cell. Gap junctions are found in many organ systems. For example, some muscle cells, specifically cardiac muscle cells, will spread electrical signals using gap junctions, so some neurons can synapse at a single site and still have that message pass down to many cells beyond it through the gap junctions. It saves the neuron from having to pass the message individually to every cell itself. This also enables coordinated contraction of the heart from bottom to top, so that blood is pumped out of the heart, with the signal originating in the SA node as outlined in the cardiovascular chapter. Pretty efficient, right? Flash quiz. What layer of skin is found only in the palms and soles? That's right, stratum lucidum. Bonus points. Which is the stratum lucidum layer? It's right here in pink. This section is a crucial one for you to understand as you transition into your wards experience. This guide attempts to explain the differences between seemingly similar dermatologic terms. Some examples have been provided here to help you with this. Let's start by talking about macules, patches, papules, and plaques. What is the key differentiator for terms? That's right, the size. A macule is a flat discoloration of the skin that is less than 1 centimeter in diameter. If, however, the discoloration were greater than 1 centimeter, it would be called a patch. Similarly, if the skin lesion were less than 1 centimeter, but now it were elevated, it would be a papule. And if it were greater than 1 centimeter and elevated, it would be called a plaque. A classic example of a papule is a small pimple like you may find in typical acne. However, plaques are the more extensive skin lesions you'll see in patients with psoriasis. If the plaque has a flaky top layer, then you would call this feature a scale. It's shedding the stratum corneum. Let's look at vesicles and bullous. What's the important distinguishing feature here? Again, the size. A vesicle is classically just a smaller, fluid-filled blister, like you would see in chickenpox. If it were bigger, it would be called a bulla. If a blister is filled with pus, it's called a pustule. If any of these three were to pop and then dry over, it would form what's called a crust, a common finding described in impetigo, which we'll discuss later. A wheal is a vesicle that appears transiently. Now, what is a common cause of a wheal? Usually from a hypersensitivity reaction, like hives. Flash quiz. How would you describe this lesion? Well, this is a patch. This list contains terms related to the architecture of the skin when you look at it with a microscope. Do you recall the 5 layers of the skin? The stratum corneum, lucidum, granulosum, spinosum, and basalis. We'll see now how different pathologies will have classic findings on histology that affect this diagram of the skin. In diseases like psoriasis, a common finding is thickening of the stratum corneum, the topmost layer, which is called hyperkeratosis. What if hyperkeratosis occurs in the stratum corneum with nuclei retention? It would be called parakeratosis. Do you recall what happens in pemphigus vulgaris? Antibodies cause separation of epidermal cells. This blistering is called acantholysis. Acanthosis, which sounds similar, is a problem of the spinosum layer, causing hyperplasia and discoloration. The next set of diseases we'll touch on are the diseases of pigmentation. There are 3 of them that we'll discuss here, but there are in fact many more. Others, like albinism, are general terms that describe a spectrum of diseases. One form of albinism is caused by a decreased function of the tyrosinase enzyme, a critical enzyme in the formation of melanin. If you look at their skin histologically, would you expect to see changes in the melanocyte number or average melanin production per melanocyte? You should expect to see the same number of melanocytes, but each melanocyte produces less melanin. Defective tyrosine transport can also result in a similar presentation. A different form of albinism occurs as a result of poor migration of neural crest cells into the skin. In this form, the melanocytes, a neural crest derivative, never actually make it to the skin, and therefore a decreased number of melanocytes is the actual cause of this disease. What's another disease that results from the migration failure of neural crest cells? That's right, Hirschsprung's disease. A different disease entirely is called vitiligo. Here the problem is more focal and usually not as generalized as it is in albinism. The main reason for this disease is because of a decrease in the number of melanocytes, usually as an acquired phenomenon, which means the neural crest derivatives made it into the skin and were working fine until some idiopathic insult caused them to be destroyed. A final skin pigmentation disorder is the one seen in pregnancy, which is called melasma, or the mask of pregnancy. What else might cause melasma? You often will see this in patients with OCP use, indicating the role of hormones in this hyperpigmentation. Flash quiz. Which skin layer does acanthosis affect? The stratum spinosum. Let's move on to some common skin disorders. Often, questions on step 1 will show you a picture and expect you to identify the disease process. Sometimes you'll be given a picture and asked to choose an answer about its malignant potential. These questions can be quick gimmies if you study these facts. Many of us are all too familiar with acne. It's most common in teenagers but can occur at any age, usually on the face and trunk. It's an obstructive inflammatory process of the pilosebaceous unit of the skin. Atopic dermatitis is an important disease to know. You likely already know it's more commonly called eczema. Now, where does eczema present? Usually on the flexures of the extremities, and it itches like crazy. Usually atopic dermatitis is just one piece of a greater atopic triad. Do you remember the other two symptoms? Good. Allergic rhinitis and asthma. In infancy, it appears on the face. Later in life, it's seen in the skin flexures like the antecubital fossa. Atopic dermatitis is often compared to a different dermatitis called allergic contact dermatitis. While you'd expect atopic dermatitis to come on very quickly since it has some allergic and therefore IgE-mediated signaling, allergic contact dermatitis does not follow the same rule. Here, the skin changes result from a delayed type hypersensitivity reaction. Do you remember what type of hypersensitivity reaction is delayed onset? Good, a type 4 hypersensitivity. This is a problem due to contact with an allergen. What pattern would you expect? Well, the lesions would occur at the site of contact. The classic example of this dermatitis is the reaction people naturally have to poison ivy. If a patient comes in claiming to have contacted poison ivy only 30 minutes prior, and they now seemingly have a reaction on their skin, it's unlikely to be poison ivy only because it takes a couple days for a reaction to develop. This is another great example of how questions can be answered by knowing chronology of diseases and the rapidity of onset. Now, what is this? Well, it's a mole, or a melanocyte nevus. Most of the time, these are benign, but every now and then, a melanoma can originate from melanocyte nevus. How would you describe an intradermal nevi? It's papular because it's solid and raised. Now, what is this? It's a junctional nevus. Now, how would you describe it? As a flat macule. Now, the classic lesion in psoriasis is multiple salmon-colored plaques with silver scale over them, particularly on the extensor surfaces of the extremities, i.e. the knees and elbows. Do you recall what skin disorder occurs on the flexures? Good, eczema. In psoriasis, when you look at the skin of these patients with microscopy, there is acanthosis. So which layer is increased? Good, the spinosum layer. You can also see parakeratosis, meaning nuclei are retained in the corneum layer and a small granulosum layer as well. You should definitely memorize these findings, as their presence is usually a pretty big hint that the answer to the question is psoriasis. There are a few diagnostic clues that may help you to confirm a diagnosis of psoriasis in a patient who presents with a rash. The first is the Auspitz sign, which means that when a scale on the lesion is scraped off, that spot will tend to bleed. The second clue that you might get is that psoriasis is a systemic disease that doesn't only affect the skin. What else should you look for in patients with psoriasis? You can look for psoriatic arthritis, nail pitting, but there can be a whole variety of disease manifestations. Flash quiz. If a patient with psoriasis also has arthritis, what might you expect to see on an X-ray of the hand? Pencil and cup deformity. Okay, so what is this? This is rosacea. Now what is rosacea? It's an inflammatory process that results in erythematous papules and pustules without comedones, as seen in acne. Some patients who are prone to facial flushing also have rosacea. What happens if it goes on chronically? You may see patients with rhinophyma, as seen here. The final common skin lesion that we'll discuss is seborrheic keratosis. This is a flat, greasy, pigmented skin cell tumor that includes keratin-filled cysts and happens most commonly in older adults. It's classically described as looking like it is pasted on but cannot be scraped off, and it can truly happen anywhere on the body. Are these lesions malignant? Well, no, not as a single isolated lesion. However, one classic board's question about this skin finding is that it can reveal an underlying disease. Do you recall the sign of lesser Trillat? Multiple seborrheic keratoses appear rapidly, indicating an underlying cancer, often of the GI system, and less commonly a lymphoid neoplasm. So what are verrucae? Well, these are warts, soft, tan-colored, and cauliflower-like. If you look at them under microscopy, they show epidermal hyperplasia, or hyperkeratosis, as well as koilocytosis. Sometimes they're described as looking like church spires. There are many different types of warts, from the commonest form, verruca vulgaris, that might appear on the hands, to condyloma acuminatum, which can appear in the anus or the genitals. Which HPV types cause warts? HPV serotypes 6 and 11 most commonly. Do these warts have malignant potential? No, you expect cervical cancer with HPV 16 and 18. Urticaria is the term used to describe hives, which are in fact wheals that are very itchy. Now, why are they itchy? Mast cells release inflammatory factors. You can see this in a wide variety of allergic responses. Biopsy of these lesions will show dermal edema and lymphatic channel dilation.